This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new here, welcome. And for those of you who are regulars, welcome back. Just as a reminder, I'm a med-peds trained pediatric hospitalist here at UPMC Children's Hospital Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. And we have been coming to you since 2016. We are now at our 10-year anniversary here at PHM from Pittsburgh. And this is one of two series we're doing this year, which we're going to talk about. So first, I wanted to say, remember that's free CME courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Just go to the link at the bottom of the description of the podcast to get it. But like I was saying, this is one of two series we're doing this year. The first one is vaccine preventable illnesses, and this is a series on ADHD. It's one of the most common pediatric diagnoses that we have been avoiding on the podcast, mostly me, and we are now tackling head on. So to do that, we are going to start with this first episode in this series, which is kind of like, for those of you who are attendings or residents, refreshing what you may have learned in residency or in medical school even, or as studying for your boards on ADHD. Just kind of a refresher on some of the stuff we would expect us to know. And then episodes 2 and 3 are going to go into more daily life struggles, logistical issues, things like that, is interesting and good for us to know as physicians. But now to do this, we need to get an expert who we can trust, knows what they're doing, and can help guide us through this. And thankfully, we found just the right person for this. So I want to welcome on the show Dr. Heather Joseph. Now, Dr. Joseph is a board-certified child and adolescent psychiatrist and assistant professor of psychiatry and pediatrics at the University of Pittsburgh. Her research interests are in early detection of ADHD, in the development of preventative interventions for young children, at-risk or expectant parents with ADHD to improve outcomes for families. She's a founding member of the Early ADHD Consortium, an international collaboration of investigators working to advance research on the early ADHD phenotype and biological and environmental mechanisms influencing the emergence of ADHD from the prenatal period through early childhood. Her research has been supported by the National Institute of Mental Health, the American Academy of Child and Adolescent Psychiatry, the Klingstein Third Generation Foundation, Fellowship in ADHD, the Brain Behavior Research, and Your Mom Cares Research Brilliance Award. She's presented her findings nationally and internationally and has over 30 peer-reviewed publications on ADHD, including a top-cited article of 2023 in the Journal of Child Psychology and Psychiatry. In addition, she's a practicing member of the Consult and Liaison Service at the UPMC Children's Hospital Pittsburgh and both the Children and Perinatal Telephonic Psychiatry Consult Service Tips Program. So, Dr. Joseph, thank you for being on the show. We appreciate it.
Thank you for having me. It's a pleasure.
Okay, Heather, this is a CME podcast, so as you know, we have to do our disclosures. I will go first and kick it out to you. I have nothing to disclose.
Thank you. I have NIH grant funding, but it will not influence the things I say today. That's my only disclosure.
Wonderful. Heather, this has been a topic, as you heard, I've been avoiding because it's a big topic. It is not small, and there is new data that I just was avoiding covering all this. But we're going to tackle it. So do you want to start, should we start with just defining ADHD? Would that be helpful?
Yeah, I think that's a great place to start. So when we're thinking about defining ADHD, I think it's important to think about the DSM diagnostic criteria for ADHD. And that has changed into the DSM-5. So the most recent criteria for ADHD is that the children or adults are meeting 6 or more symptoms of either inattentive or hyperactive impulsive symptoms. And if you are presenting with a combined subtype, you need to meet 12 symptoms. So it's not 6 of either category, it's 12 total for combined. It is a neurodevelopmental disorder, which means it begins in childhood, and that's reflected in the diagnostic criteria in that at least some of the symptoms should be present before the age of 12. And that is a difference from prior editions of the DSM, which said 6. And partly that is recognizing that people are presenting later with a diagnosis, and it might be hard to remember or have evidence to support that symptoms present before age 6. So that's sort of why that was changed. The other things that are important in the diagnostic criteria are noting that the symptoms are out of proportion to developmental age. So everyone has some inattention. Young kids definitely have inattention. Hyperactivity and restlessness changes over developmental phases, but this is in relation to other peers at the same developmental age, and that it's causing significant impairment and that the symptoms are present in more than one setting. The last thing is that it is not due to another mental disorder. So, for example, if you have depression and you're presenting with inattention, difficulty concentrating, that is not sufficient to meet the diagnostic criteria.
Well, that sounds wonderful. Do you want to, why don't we talk about the prevalence of it? Because that changes a bit. And there's a sex difference, which we should talk about. And then
Yeah.
we can dive into some of the core features.
Yeah, great. So yes, there's a lot of news media coverage probably hitting recently about changes in prevalence of ADHD. And that is what we're seeing in papers that are coming out in terms of what is the prevalence. There are reports that span from 5% to close to 10% of the population. And part of that change in representing people with a diagnosis or the meet criteria of ADHD is due to probably recognition of the disorder. So more people are identifying it, and it's either identified in clinics, in schools, or they're self-identifying and seeking treatment. I think there's less stigma around having ADHD, which might increase the what appears to be a higher prevalence then as people are more accepting of a diagnosis and treatment. And then, as you mentioned, that there are differences by sex. The interesting thing about that is in studies that are looking at prevalence of boys versus girls in young age, you're seeing like a 2.5 or 3-to-1 male to female presentation. But as age proceeds into adulthood, the prevalence really is closer to 1-to-1, which raises a lot of questions. Since it's a childhood onset disorder, how is the prevalence and the rates normalizing in this 1-to-1 fashion into adulthood? I think there's a couple things that could be explaining that. One thing is that girls are often under-recognized in childhood. A part of that is due to how their symptoms present. Oftentimes, girls present with more inattentive symptoms, and that can lead to them being underdiagnosed or under-recognized. They may be quietly inattentive and not disruptive in a way that isn't getting recognition by teachers or parents, and then that can certainly result in not being referred to treatment.
Okay.
Yes.
So, go ahead. Sorry.
Okay. That's okay. And then the other thing is that as girls age on, as girls develop over time, they have a lot of different transition periods and take on different responsibilities. And there may be transition points where they start to have more self-awareness of their symptoms. And so even if their parents or teachers hadn't identified it, they start to self-identify and seek treatment. So one or a couple examples of that would be when they transition to independence. They're leaving the home. Maybe they're going to college or starting a job, and they have to take on the responsibility, the organization, the planning. Maybe more symptoms are presenting in those situations. And in parenthood, so as they transition to parenthood and have to plan and take care of others, that can certainly put a lot of demand on their cognitive resources. And that's another time that we see women presenting for diagnosis and treatment.
So women were able to, or theoretically are able to compensate up until that point, like leaving the home as young adults and or having children of their own.
Well, I think that's true for both males and females, that we definitely see people who, in the right environment, can compensate. If you have parents that are providing a lot of scaffolding and support for your day-to-day life, you might not have a lot of impairment associated with your symptoms. When you leave the home, a lot of that support goes away. And that is certainly a time that we see young adolescents and young adults presenting with more impairment due to ADHD.
And this explains there was a big social media trend that we had talked about where people were diagnosing themselves with ADHD, and it was often young women
Yes.
in their early adulthood, finding using social media to figure out if they have it or not. And from what you're saying, they were underdiagnosed because they perhaps presented slightly differently, basically not as what's the word? Not what's the word used?
Like hyperactive or
Yeah,
disruptive.
not as disruptive as the boys, so they were underdiagnosed. So
Yes.
that makes sense with what you're saying.
Yes, I do think that that explains a good majority of what we're seeing in the clinic setting for young women.
And now I want to talk about the screening now, because do you
Mhm.
think screening now has changed to kind of capture that group, to even out the playing field?
No, I don't think so. Because screening for ADHD doesn't happen routinely. It's often after there is some concerns or symptoms brought to the attention of often a pediatrician. And this happens around the age that kids are entering school. So the highest new incidence of ADHD is about age 7 to 9. And that, again, is up to the school to recognize that there's something that's happening where it's hard for the child to pay attention or to regulate their behavior, and that it's out of proportion to their peers. So I don't think we have a good routine screening mechanism like we do for depression, let's say, to identify ADHD.
Now, we talked about men versus women, but looking at other racial demographics, what I read was that children of ethnic minorities are less likely than Caucasian children to receive an ADHD diagnosis. Is that still true, or is that something to do with how we're diagnosed?
That is still true, unfortunately. And even worse than that is that even if a Black child is identified as having ADHD, they are less likely than a white child to receive medication management. So even when they do have a diagnosis, access to care is different. Now, there's a couple explanations for that that are not just driven by the healthcare system. Some of it may be cultural acceptance of mental health diagnoses and treatment. And I think that we have a ways to go to balance the equity in psychiatric care for minorities.
Well, that's sad, but I'm glad we talked about it. Now, some of the we've kind of brushed on the core features of hyperactivity, impulsivity, inattention. Can you talk about that with ADHD?
Yes. So ADHD has these three presentation types: the inattention, hyperactive, impulsive, and combined presentations. It used to be called subtypes, and it was changed to presentations. And the reason that nomenclature was changed is to reflect that these are not stable. So a child who is diagnosed in preschool may have a combined presentation where they meet full diagnostic criteria for inattentive symptoms, poor focus, poor attention, and they also have full diagnostic criteria for the combined or for the impulsive hyperactive side, where they are restless, fidgety, running around, unable to stay seated. But as they grow up, they may have better time regulating their behavior. So they don't present with as many hyperactive impulsive symptoms, and they may then become ADHD inattentive presentation. So they're not stable. They can change over time. And the DSM did try to make some changes in the fifth edition to reflect that ADHD presents differently in older children and adults, such that the hyperactive impulsive symptoms try to reflect more internal restlessness, some fidgety, some things that might be socially acceptable for adults as opposed to kids. So if you're asking, do you get out of your seat at an inappropriate time, which is in the diagnosis of ADHD, most adults are probably going to say no. They've learned how to not do that. But if you're asking, if you have to sit through a 1 hour lecture, do you feel restless? That might still reflect the same um, symptom, but presenting differently in an adult versus a young child.
That was very helpful. Thank you. Now, in terms of genetics, we get into genetics and pathology a little bit with ADHD in terms of trying to figure out how it's transmitted, the heritability, et cetera. So from what I have read, and you correct where we are currently with what I have read. I have read this is likely polygenic in terms of multiple genes are involved. There is a heritability component. There is environmental, prenatal, perinatal influences that complicates understanding, but like twin studies have shown a heritability rate of up to 76%. So fill in the gaps. What am I missing?
Yeah, I think you summarized that very nicely. There isn't one particular cause of ADHD. I think ADHD is a very heterogeneous group of likely disorders presenting with similar symptoms, and that makes it, challenging to identify how do we prevent or intervene to stop the progression of the disorder. However, we do know that they run in families. So whether that's because of genetics or it's because of the environment that's set up by having a parent with ADHD, I can't answer that clearly. But it is one of my greatest interests. So my research personally looks at parents with ADHD and enrolls their whole family, so mom, dad, and their new child, and follows them longitudinally to identify, can we see which children born to parents with ADHD might develop ADHD early on so that we can intervene with the family to try to either reduce the symptoms or reduce the impairment that results from ADHD? And some of the interesting things that I find is that parents with ADHD definitely have more parent stress, higher rates of postpartum depression. They have more challenging attachment with their infants at times, and they set up homes that are a little bit more chaotic. And all of those things could contribute to a developing child or a child that's already at risk for ADHD to potentially worsen symptoms of ADHD and associated impairment.
That is fascinating. I'm going to ask you, in terms of the naysayers, people who are online talking about ADHD and how there's clearly something we're doing that's clearly more than it was. The change in definition or the change in recognition doesn't account for how much more ADHD there is. As someone doing research in it, as an expert in it, how do you respond to those people?
Yeah, that's a great question. I think there's a little bit of both, right? So we did change the DSM criteria. So in adulthood, you can have 5 symptoms instead of 6 and still meet full diagnostic criteria. So we lower the threshold for adults to meet diagnostic criteria. We do have a society that spends a lot of time on social media or fast-paced video games and different things that draw away from needing to spend a lot of attention on something for a sustained period of time. And boring tasks are still boring. So it may be harder. But there is definitely a difference when you meet someone with ADHD and you talk to them about their experiences and how their symptoms are impairing their lives. I think it's hard to deny that that exists. And, I spent a lot of time going into people's homes that decided to participate in my research study and doing clinical interviews with new or expectant moms and dads. And it's really taught me a lot because I'll talk to one parent and ask them about their symptoms in childhood, what it was like for them, and then also what it's like for them in adulthood. And it's interesting to see even people who weren't diagnosed, but they suspect that maybe they have ADHD. They can give me very clear stories about what was challenging for them as children and maybe some of the things that were put in place that prevented them from getting a diagnosis. Like, for example, if someone had a parent that was a teacher, they might know how to provide the supports to allow them to do well academically, how to study, how to, do what they need to do to keep up with their grades. I also had people who said, my parents put me in a lot of activities. I was never bored. I didn't have to sit still. I was constantly doing sports and things. And that kept them, not getting recognized. There wasn't a problem there. That's great. And then I had people even into their adulthood who talk about their partners compensating. So when I ask about symptoms in adulthood or impairment, they said, well, is it before or after I met my partner? Because the partner now takes on, the picking up the kids, the planning the activities. So there may be things that these are good things. These are coping skills perhaps that we can set in place where someone can help with reminders or someone can make it so that the challenges that might be associated with ADHD aren't present for them.
That was a great explanation. Thank you. That was wonderful.
Yeah.
Pathology. What I know, Heather, and I know I'm missing stuff, is that there's some neurotransmitter dysregulation of the fronto-subcortical network. We think particularly of dopamine and serotonergic receptors and proteins. What do we know and what do we not?
Yeah, I think there's a lot that we don't know. What we do know is that stimulants, which is the most commonly prescribed medication for ADHD, is highly effective in treating ADHD symptoms, and it works to increase or sustain dopamine levels in the brain. So we do think that dopamine is playing a role in ADHD. The other medications that we use, things like the SNRIs, include norepinephrine. So often there is dopamine and norepinephrine that might be playing a role in ADHD symptoms. I think we also know that there are differences in brain structure and function in individuals with ADHD, although, again, with the multiple ways that ADHD might present, it's not as clear as let's get a brain scan and find a lesion or a region that is delayed in development. But overall, in large studies that collect brain imaging that either look at structure or function, when we look at large groups of people with ADHD, we see that in general, their brains might have more delays on the order of like 3 years compared to their peers. And so in childhood, that is very significant. And that might explain some of these symptoms that we're seeing.
Do these brain delays do they ever catch up, like into adulthood?
Yeah. So I would say that I think that some of them maybe do, and that certainly people grow out of ADHD symptoms. So there are definitely people who are diagnosed in childhood and no longer meet criteria into adulthood. It's about 2/3 maybe that continue to meet diagnostic criteria into adulthood. But even more of them tend to continue to have impairment even if they don't meet diagnostic criteria. So there is some impairment that's happening even if you grow out of your symptoms.
Now, and on the parent blogs or in the parent websites for kids with ADHD, they talk a lot about maturity and development is lagging in a kid with ADHD by about 2 to 3 years compared to their peers without it.
Mhm.
Is that from these studies, you think, from these neuroimaging type studies, or is this something else?
That's a great question. I don't think that it would be from the same studies because they are looking really at the brain structure and function in a large group of kids across developmental stages, but it does map the timeline on. So there might be some correlation between, the time frame of brain development and social skills. We do know that, we talk a lot about inattention, hyperactivity, but those aren't the main things that are the problems when people present. Maybe the hyperactivity is, but definitely social skills, impairments with peers, that is a huge problem. And even more so for girls, females, they tend to have more social problems and it results in more internalizing disorders for girls with ADHD. So there's one longitudinal study of girls that followed them in from childhood into early adulthood, and they found significantly higher rates of depression, anxiety, suicidal behaviors, including non-suicidal self-injury in girls with ADHD.
And when you say there's an issue, there's issues they have with socializing. Is it maintaining friendships, keeping friendships? Can you at all hammer it down?
Yeah, I think that it has to do with some social cues. So if you're inattentive in conversations with your peers, if you're intrusive in conversations, if you're impulsive in the decisions you make, it may be hard to develop and sustain good friendships.
Okay. Wow. And so that's so there's an increase, and with boys, since with girls as they go through adolescence, there's an increased risk of depression and anxiety, you said suicidality as well, correct?
That's
Is
right.
there the same risk in boys?
You definitely see high rates of comorbidity in internalizing disorders across both genders. I just think it's more pronounced for females.
Well, it's not to change us back to early childhood, but the next thing I had that we were going to cover is some intrauterine pregnancy exposures and birth issues that are linked with ADHD. So for like I figure the best way I'm just going to read them, and then you
Sure.
tell me if I miss anything.
Okay.
Intrauterine pregnancy exposures linked to ADHD include alcohol, tobacco, and opioids, and it's less clear about the contribution of any maternal therapeutic meds. Is that correct?
Yes, that is correct.
Wonderful. And then birth issues associated with ADHD, premature birth, low birth weight are both linked to the inattentive type. Birth complications like causing prolonged stress on the infant, like intrapartum hemorrhage, toxemia, eclampsia, prolonged delivery. There's no causal mechanism for this, but it's been identified with it. Do you
That's
agree?
right. I definitely agree. And I do think a lot of that is related to brain development. So we know that all of those conditions can affect neurodevelopment in these young infants. So I think that that is likely what's contributing to the ADHD symptoms.
And then early childhood exposures, lead, organophosphates, and polychlorinated biphenyls are linked to increased rates of ADHD.
Yes.
And then this one, adverse childhood experiences and psychological adversity. So it's like young trauma, basically.
Mm.
So children of war-torn countries who are going through that, but also is it any kind of trauma, anything that increases adverse childhood experiences? Is that right?
Yeah, so that one I think is a little less clear. That one is very challenging in that that's more of the environmental factors that if you have PTSD, you're going to be inattentive. You're going to have different behaviors and reactions, and I think there's a lot of discussion about the idea of complex PTSD, so ongoing and sustained trauma that maybe isn't identified as a single event, but things like you're saying in these early childhood adversities. And I do think it can change brain development. It can also present with ADHD symptoms, and there may be less structure and development from the parents that can help guide child's behavior over time. So that one's a little less clear to me.
And then genetic and or neurodevelopmental syndromes with increased risk of ADHD. We have Fragile X syndrome, NF1, velocardial facial syndrome, tuberous sclerosis, and Williams syndrome.
Yes.
Okay. And then other neurodevelopmental disorders where there's an increased risk of co-occurring ADHD, autism, intellectual disability, epilepsy, cerebral palsy, Tourette's, language impairments, and learning disability.
Yes, and I think those are a couple things to talk about with that group of disorders is that the change in the DSM-5 allowed for you to have an autism and ADHD diagnosis simultaneously, where prior versions of the DSM did not allow those to occur together. So that could certainly also increase the prevalence of ADHD. We know a lot of children with autism have inattention and hyperactivity. So that's one thing to point out there. There was another thing. I just can't remember what it was. Oh, the other thing is that, at Children's Hospital, we have the cardiac unit, and a lot of individuals with congenital heart disease are seen in the ICU and followed longitudinally in the developmental clinic. And the developmental follow-up clinic sees very high rates of ADHD. The third thing that I would say is that you mentioned learning disorders. Those are important to address because they may present with ADHD symptoms, even if it's not ADHD. So we want to make sure that we're addressing learning disorders and making sure that those are either they can be comorbid or they might be presenting with ADHD symptoms that maybe need a different treatment.
So then that would be a full neuropsych eval to figure out learning disorders, et cetera. So
Yes.
on the inpatient side, if we're seeing a patient and the parents telling us, and perhaps there's some inattentive symptoms there, the real question is there a learning disorder as well? So that's a whole neuropsych evaluation.
That's right. And I'm actually glad you said the word neuropsych evaluation because I think a lot of people think that you need to have a neuropsych eval to have a diagnosis of ADHD. And that is not true. ADHD is a clinical diagnosis and it's not required to have a neuropsych eval. But there are many cases where a neuropsych eval can be informative, just like you're saying with a learning disorder. That would be an excellent reason that you might pursue a neuropsych eval. And neuropsych evals can be particularly helpful in accessing services like an IEP through the school and getting support set up. So there are times to pursue a neuropsych eval in ADHD, but it should not be a requirement for the diagnosis.
And then for physical exam for us as hospitalists, let's say, one of the points is to help rule out one of these other conditions. We talked about NF1, tuberous sclerosis, all these other conditions, evaluating growth parameters, dysmorphisms that may suggest any underlying genetic condition. And there's no other health conditions that may preclude or mitigate medicine management. That's one of the reasons that we have our exam.
Mhm.
Let's talk about, let's talk about prognosis. I don't know that we, for the podcast, have to read through the signs and symptoms.
Mhm.
Just as you said, the only thing I'll say is for the DSM-5, I believe, says that ADHD should be conducted in children or adolescents aged 4 to 18, this last AAP guidelines, who demonstrate academic or behavioral problems and symptoms of inattention, hyperactivity, or impulsivity. And then let's talk about prognosis, Heather. What can we expect? Because often, if we see these kids in the inpatient setting, it's from a trauma or accident or behavioral issues, aggressiveness outbursts, some other psychiatric condition in addition to it.
Yeah. So that's a great point. I do think in hospital medicine, we're seeing probably the most severe cases. So when we're thinking broadly about ADHD, many of these individuals will not need an inpatient stay for a medical or psychiatric reason and will do well in outpatient settings. But yes, they are at increased risk of accidents and higher rates of car accidents across the lifespan. So something to think about with your adolescent patients and young adults, and then higher rates of presenting to the ER than.
Well, I was going to ask the other question that always comes up is for our kids who have ADHD, who are in for something else.
Yeah.
How important is it to continue their medications? What are the pros and cons?
Okay, this is a great question. So, the largely we'll be talking about stimulant medication when we're thinking about should we continue or discontinue an ADHD medication in the hospital setting. If they are taking a stimulant, it's only going to work for the 8 hours, 6 hours that they're taking it, and largely we're treating symptoms that might be impairing their school day or even like club activity involvement. So if they're not being expected to participate in something that requires them to be attentive or behaviorally controlled, then it's okay to stop that medication temporarily in the hospital setting while they're receiving other treatment. However, if they have very severe symptoms and they're going to have trouble even staying in their bed or in their room, it's definitely going to be worth continuing it. It just depends sort of why they're there and what is needed from their care.
Well, that's helpful to know. That's kind of how we've gone about it. But this other category that came up of unspecified ADHD, can you talk a little about that?
Yeah, so I think this is, we're mostly thinking about children who maybe have some of these other factors, like you're saying, the complex childhood traumas that might be presenting with ADHD symptoms, but it's not quite clear that ADHD is the primary concern here. Or if you're sub-threshold, not quite meeting the full diagnostic criteria. Often we're not using that diagnostic code or giving that diagnosis at least in the patients that we're seeing.
The only other group that was surprising to me was complex ADHD, which I did not know about, which I could see us having to see in the hospital. It starts before 4 years of age or after 12 with co-occurring conditions, moderate to severe impairment, inadequate response to treatment. Is this a large group? Did I summarize it well?
Yeah, so that's actually not a diagnosis that I've ever used, but when you describe it, I do think it sounds like children who also have other neurodevelopmental disorders. Often we see children on the autism spectrum don't respond to stimulants the way that children without autism spectrum respond. And so that to me sort of feels like it might fit that category.
Okay. So we've talked a little about how kids with ADHD may grow out of it, may not. It depends. And how we've talked about how there's multiple factors, whether it's genetic and environmental that are in play. We've talked a little about treatment, and that's stimulants. Anything else for treatment?
Yeah. So, a couple things to think about for treatment. Stimulant medications are highly effective for treating ADHD symptoms, but they are not going to change all of the associated impairments or challenges. So, one thing that in my role as a TIPS consultant, where I speak with pediatricians, I get a lot of calls about kids who have been titrated on a medication for ADHD, and at appointment after appointment, the parents coming in and saying, they're not better. It's not better.
Mm.
And now they don't know what to do. And my first question is always, what's not better? I think that we really need to be clear about what are we treating with stimulant medication or any medication for ADHD. If parents are expecting that grades will change because of medication, that's not necessarily true. They need to learn how to study, how to organize their homework or projects, and the medication will allow them to have the bandwidth to be able to attend in class, learn the information, and maybe sit long enough to complete the project. But if they haven't learned the study skills, organizational skills, it won't necessarily translate to better grades. And I think the same is true if they say, well, their room is still a mess and they're, not doing all these things. We should be very clear up front, what will the medications do and what won't they do? And so there's always a role for talking about therapy, whether that's parent-child interaction therapy, whether it's parent management training in terms of how to shape behaviors with young children, or individual training with children or young adults, adolescents around organization, planning, really trying to target some of the executive dysfunction that is impaired in ADHD.
That is fascinating. Now, and one of the things I didn't know about treatment is that if someone with ADHD is adequately managed, they have improved academic outcomes, lower rates of mood disorders, lower rates of substance abuse, less criminal behavior, and less motor vehicle injuries and traumatic brain injury. So it's remarkable how much better they do with stimulants and other appropriate treatment.
That's right. Yes, it's definitely worth treating. And that doesn't mean that you have to start with a medication. So certainly if a family comes in and is interested in trying to put in place behavioral strategies, that is appropriate and they can start there. And if you try a stimulant and a stimulant isn't tolerated, often due to low appetite or things like headache and upset stomach, then switching to a non-stimulant would be the next line. One thing to think about with stimulants, there are two classes of stimulants, and unfortunately, there's no good way to predict which class of stimulant will work for which individual. So there's not a wrong answer as to which one to start. You might start by asking if anyone else in the family has tried a stimulant and if they responded well to one class versus the other. And if a child or patient has an adverse reaction to one stimulant, it is still advisable to try the other class of stimulant.
And in terms of non-stimulant medications, what are they that you were
Yeah.
alluding to?
Yeah. So the ones that are often used for ADHD would be things like alpha agonist. So alpha agonists are used very often in young children to help with more of the hyperactive impulsive symptoms. They can be an adjunct to a stimulant or they could be used alone. They also have an added benefit of helping with sleep. So children and young adults with ADHD all report sleep problems almost. It's about 70 to 80% of individuals with ADHD have sleep problems. So I see alpha agonists being used, trying to sort of tackle the hyperactivity, impulsivity, and help with sleep. And then aside from alpha agonists, there are things like Strattera or atomoxetine, which is an SNRI, and Quellbri, which is the newer version that is also an SNRI. And the two of them have different methods of action, but they are kind of analogous medications. One thing to think about is that atomoxetine or Strattera takes several weeks. So unlike a stimulant where you see an effect the day you take it, the other medications take weeks to build up. So that's important for providers and patients to be aware of. And then a third option is Wellbutrin or bupropion.
Mm.
So that's a medication that is off-label but often used for ADHD, and it's another good choice if you're treating an individual who either didn't tolerate a stimulant or also has comorbid mood disorder symptoms.
Oh, that's very helpful. And now you talked about this with sleep with the alpha agonist, but one of
Yeah.
the things that was recommended, that seems recommended, is trying to fix sleep hygiene issues for kids with ADHD to really help therapy as well.
Yes. Right. So when you think about a night that you didn't sleep well, the next day you have a hard time focusing. You might be more restless, more impulsive. So there's a real overlap between executive functioning and sleep. And it's very important to understand how sleep is playing a role in ADHD diagnoses. So we have young children that maybe have a true sleep disorder, a primary sleep disorder that will present with ADHD symptoms. And we want to make sure that that is not the cause of ADHD. So if we treat obstructive sleep apnea, if the ADHD symptoms go away, that's not ADHD. So there's definitely the bidirectional piece of sleep and ADHD that is complicated.
I have to tell you, when I first read that, I did not realize that sleep disorders, specifically obstructive sleep apnea in childhood, can masquerade as ADHD. But the way you described it makes a lot of sense. Now, you talked about the behavioral modification therapy. That's mostly used for younger kids. Is that right?
Yes. So the parent behavioral management is preschool. You could go as young as toddlerhood, but toddlerhood and preschool, and then early childhood, because a lot of this is skills like attending and praise. So you want to attend to your child, praise the behaviors that you want to see repeated, and then things like planned ignoring of things you don't want to see. So it's really a parent's way of sort of increasing positive behaviors, decreasing negative behaviors. And then we teach things like behavior charts or incentive charts that work very well for young children and maybe are helpful as children grow up, but they're a little less effective once you get to adolescence.
The one thing I wanted to make sure we hit again is the stimulant medicines work. We talked about the norepinephrine and dopamine, but they work by increasing norepinephrine and dopamine transmission in the prefrontal cortex. And then the only thing I think we should cover is the most common adverse effects of these medications to know as hospitalists.
Yeah. Well, I would say that the most commonly reported are decreased appetite. You might have headache, upset stomach. The things to be most concerned about would be ca- cardiac concerns. So we do not require an EKG before starting stimulants, but certainly we want to ask about history of cardiac illness in like close family members, particularly sudden cardiac death. And then these children that are taking stimulants, we do see increases in blood pressure and heart rate. So those are things to be aware of in the hospital setting.
For sleep, you talked about sleep onset delay in all kids with ADHD, and if that becomes worsened with medicines, with stimulants, is that a reason you would switch to another class of medicine?
Yes, if it was pervasive and really they could not fall asleep, you might consider another medication. But I think often what happens is you just sort of switch the formulation of the medication. So instead of the longest acting, you might use shorter acting medications and try to avoid them in the evenings and close to bedtime.
Okay. Yeah, timing could be helpful. I guess the stuff we wanted to cover for this now is the stuff on social media. We're still seeing a lot on magnesium and other supplements. Is this a thing? Is it helpful or not? What do we know?
Yeah. So I think it's not widely implemented in terms of supplementation. I did spend some time trying to dig into the literature so that I could better understand what is out there. And there are a handful of studies. They're small, they're in very different groups of populations, and there's a signal that perhaps supplementation with magnesium might be helpful, but I think that there's still a lot to be learned in terms of for who and how much and what the long-term outcomes might be. So I think it's an area of future research that maybe is promising, but we don't yet have enough to make recommendations.
Well, now, Heather, this episode laid the groundwork, kind of the background information for everyone. So when we get to episodes 2 and 3, we have we're all coming from the same place. Is there anything you wanted to cover or make sure we covered that we did not cover?
Let me check my notes real quick.
Sure.
The only other thing that I might say about when you're thinking about starting a medication is that there are some studies that have found that the order of treatment matters in terms of if you start with a medication, some families might be less willing to engage in therapy after. So it may be important to think for mild cases of ADHD, should we start with therapy first and see how things improve before starting with a medication? That's just something to kind of keep in your mind, and maybe is important for even the youngest children, where parent management training is the first line recommendation for preschool age kids. If the child is safe, then maybe start with the parent management training or therapy referral. And certainly if the symptoms are so severe that it's impairing their safety, then medication would be indicated.
That's a great way to end. This was a great episode. Heather, thank you so much for joining us.
Thank you for having me.
All right, everybody. We'll see you on episodes 2 and 3.
As a reminder, free CME is available, and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh, and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guests, and special thanks to all of you who take the time to join us. We know that your time is valuable, and we appreciate you sharing it with us.
Please feel free to email my dad at tony.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.